technique of physics principle to see whether we can apply this into our clinical practice. Now, despite all the advances in basic medical treatment and compliance improvement, and also the surge of surgery for asymptomatic carotid disease, we still have a major problem of stroke in the community, and stroke today remains the third leading cause of death, particularly in the Western world. Now, what we need to know is what is the correct or the accurate mechanism of stroke in all these patients, and how it can guide us in trying to provide the most effective care and subsequent therapy. And we all know that embolism counts for about majority of the ischemic strokes, and the sites for this embolization comes from in this territory, and majority of them, as you will see, comes from the intracranial vessels, the carotids, the aortic arch, and the ascending aorta. And the cardiac cause accounts for about 20% of the embolization. Now, we know that the characteristics of this embolism, emboli, that majority of the cardiac chamber emboli are large, and they are likely to cause severe stroke. Whereas those which are arising from the large vessels, including the carotids, the aortic arch, and the ascending aorta, are rather either they can be large, comprising of thromboembolism, and they can lodge into the medium arteries. They can be, majority of the time, small. That includes cholesterol and crystal embolism, and they can go, and usually they result from the rupture of atherosclerotic plaque, and they go into the large or medium arteries. But we don't know exactly which goes to where. Now, there are two things that is important when we're treating the stroke. First, that how can we reestablish the blood flow into the territory which has been affected by the lack of the blood flow. And secondly, how can we prevent further strokes by giving treatment which is adequate or appropriate, for example, whether it is anticoagulation with warfarin and other oral agents, or whether it is going to be antiplatelets to address the platelet activation and other things that goes with it. Now, in order to do that, we need to know whether it is an embolic source from the heart, or it is an embolic source from this atherosclerotic plaque, from which all this platelet debris or thrombus which has been embolized. So for this, what we need to know, first of all, the site of infarction that we know from our clinical examination as well as from the MRI or CT scan findings. But we don't know whether this emboli is coming from the heart or from the arterial diseases, or in some instances, in both these cases, in patients who have got carotid disease as well as cardiac problems or cardiac arrhythmias. So there is a missing link, even though we know that there is infarction, but we don't know where it is coming from in some of these patients. Now, what we need to know, therefore, is what are the hemodynamic factors which govern the path of these emboli coming from the source. And when the emboli arise, how they are distributed, what guides or what governs the distribution of these emboli into the different territories, and which particular arteries they flow when they arise from the source. So therefore, we want to establish the link between the source of emboli and the destination of this to cause the infarction. So what we decided that we will look at the particle size, the density, and the release location. By taking this criteria, then we will have to see which area of the brain or which area of the feeding arteries they're coming from, and which area the destination arteries they're going into. So taking this into our research program, so we then decided to the following things. So we looked at the feeding arteries, which are the three main arteries that go to the brain: the right internal carotid, the left internal carotid, and the basilar artery. And then other main arteries in the cerebral artery, which comprises of the middle cerebral artery, which is a medium group of blood vessels, and the smaller vessels like posterior cerebral artery and the anterior cerebral artery, which are small and short, whereas the anterior cerebral artery, which is a small and long vessels. Now, this kind of classification has got meaning because the particles tend to move into different territories depending upon the length of the blood vessel, depending upon the size of the blood vessels, and that is important in this research. Prior to our research program, there are only 2 articles that were published in the world literature, and one which looked at simply by flow rate ratio at the bifurcation, and they concluded that large emboli preferentially would go into the wider vessel. The second study, which again looked through the physical replica of the major cerebral arteries, they also concluded that large artery attracted higher number of emboli than the flow rate ratio at the bifurcation. But this is the fundamental finding, those 2 research, they never used any hemodynamic data using the particle density, size, and mass to see where these particles are likely to go. Now, this is a very busy slide, but this is what it describes as to the procedure of this research. And the research uses mostly CFD simulation, and we try to release particles at the feeding arteries and also looked at the distribution of these particles in the brain. Now, the particles were divided into 3 major diameters: 200 micrometers, 500 micrometers, and 800 micrometers. Then also we changed the particle density as to 800 or 1056 or 1300. And then we looked at whether the particle is released in the center of the blood vessel or whether the particle is released from the wall of the blood vessel and their direction of travel into the brain. And then we conducted about 18 simulations based on the diameter, the density, and the mass of the particle. Then we developed 18 simulations. And those 18 simulations were developed based on whether the particle was released from the near wall of the artery or whether it is from the core coming from the heart. We obtained the MRI of the angiogram by 3 Tesla MRI scans, and we constructed a 3D time-of-flight sequence. And then using the software, we developed the program for seeing the flow. And then we did segmentation of the small blood vessels, particularly 1 millimeter manually, as well as automatically by using the larger blood vessel of 4 millimeter or more diameter. And then we use the various CFD simulation parameters using the physical principle of blood, and then we did the calculation. And we also use the particle tracking method using the various physical principles, including fluid drag, buoyance, and pressure gradient. These are the findings of this research. Although the research did not come to some kind of conclusion that will guide us in our clinical management, but some important observations were made. Now, as you can see that the blue particles are co-released, the near wall release particles are redly, and the A1, A2, A3 suggest they are the smallest and lightest particle, and the C1, C2, C3 are the largest and heaviest particle. Their behavior, particularly with regard to the residential time in the blood vessel, suggests that the smaller particle remain little longer in the blood vessel, as it is seen in the left side of the graph, on the top graph. On the second graph, which shows the velocity profile, and particularly the heaviest particle tend to slow their speed or travel speed or average velocity. On further study doing about the speed, we also checked or compared the velocity of the core release particle compared with that of the near wall release of the particle. And again, there are some interesting results that came out of this. there was a single peak distribution that was found in all cases. The peak distribution speed remains almost similar for cases of A1, B1, C3. And the center speeds are shifted to slow speed values for more heavier particles, particularly on the last of the right side graph. These are further research onto the speed of these particles. I will just conclude the findings from these graphs that there are M-shaped distribution of all these particles in all the different velocity values that we looked at. These have got no serious clinical implications as far as our understanding is concerned. But in the subsequent graph, you will see the particle distribution, which is important here. What we saw here, that very few particles went to the anterior cerebral artery, particularly for co-released cases, that means from the lumen of the arteries. And again, very few particles went to the posterior cerebral artery, particularly when they were released from the arterial wall or near-release vessels. Then we looked at the particle trajectory tortuosity, the tortuosity of the vessels, how the particle movement took place in those vessels. The particle tortuosity is measured by different physical principles, but it showed various interesting things. I'm not going to discuss with you the details of this, the tortuosity of the vessels and how the particle behave, but I'll give the conclusion of this particular research, and they are as follows. Co-release cases generally have higher path tortuosity than near-wall releases particle. For this specific case, this particular case, which was derived a particular MRI scan, right side cerebral arteries have slightly higher particle path tortuosity than on the left side. And particles travel at a more simpler path, particularly from the basilar artery to the posterior cerebral artery. Whether it is because these are short arteries, we don't know. So in conclusion, Mr. Chairman and ladies and gentlemen, particle trajectory is influenced significantly by its size, mass, and release location. That is something we observed which was not seen before in any of the research. The exit route of a specific particle more likely to follow the flow rate ratio of the particle when it is small. It is more likely to travel through the middle cerebral artery branches when it is a large particle. The large particles are likely to travel fast and more frequently entering into large arteries such as middle cerebral artery. At the moment, we do not know what clinical implications this research will bring, but hopefully by increasing our number of simulations, we might be able to apply this in our clinical knowledge so that appropriate treatment can be devised in future. Thank you.
We have 1.5 minutes for questions, please.
Rajiv, you comment? Yes, since there are no questions, by the time they get rolling.
I have one question.
Thank you.
I enjoyed your presentation. I'm just curious. It seems to me that what you're inferring is that particles tend to travel in the same direction over the same route most of the time, similar sized particles.
As you saw that we classified them into large and small particles depending upon the density and the mass. And yes, in a way, simplistically speaking, yes, what you are saying is right. But they also have a tendency to look at the path, look at the tortuosity of the path, and the smaller size, the short or long vessels. Depending upon that, the particle will move into different directions. And secondly, whether it is coming from the core of the artery, like, for example, coming from the heart, or it is coming from the carotid sclerosis, atherosclerosis, or aortic arch atheroma, so that might change the course in some way.
And it would be interesting to know. It's my impression that the ones that come from the heart very frequently tend to go to the same location or same general location. That's just a clinical judgment.
Yeah, that's true.
But those that come from the aortic arch, the mobile atheromata that break loose and that kind of business,
Yeah,
their course is much more random.
that's true.
Okay. Thank you.
Thank you.
Just one question. You know, you mentioned about the plaques, whether they are small or large or medium particles. What do you think is the clinical relevance of something like this? I mean, you can't gesticulate, you cannot prognosticate, you cannot even know which plaque where in the aortic arch or in the carotid artery or in the intra carotid circulation is going to rupture. So the fact that we are looking at small, large, or medium particles going one way or the other, how can we apply this clinically?
Yeah. I mean, as I said at the beginning, that this is a preliminary research, number one. Number two, we know that there are, from experience, that from the clinical practice, that we know the large, when a major stroke takes place, most of the clot comes from the heart. And when these are TIA or mini stroke, usually they come from the platelets or the debris or the thromboembolism from the atherosclerotic plaque, from the carotid and other things. So we, in some situations when there is a combined carotid disease or and cardiac arrhythmia, we don't know where the emboli has come from many times. So we are at a loss as to how to treat this patient, whether we should treat these with antiplatelets or anticoagulation treatment. So hopefully these findings, when we get better results out of these findings, we might be able to predict which is coming from where by simply looking at the particles' trajectory, and then we can recommend what kind of treatment should be appropriate.
Thank you very much indeed, Dr. Saroj Das there from London, United Kingdom, for your oration lecture.